All right, guys, this is chapter 15. It's going to be respiratory emergencies. I'm Laura, but I think I know everybody already, so I'm not going to worry too much about that introduction. Hopefully you guys are all going to be seeing the slides for this presentation on your screen, me up in the corner of the box. Don't forget that you can review all the chapter 15 materials in the Google Drive, as well as materials from previous lectures on respiratory emergencies from some of our review chapters. And those are also located in a folder in the Google Drive. It'll also be helpful if you have your medical skill sheets out with you, so you can make notes on the side of the medical skill sheets. And don't forget to write down questions that you might have so that you can come to the meeting, the Q&A sessions with questions already ready. Makes it more fun for you guys, makes it more fun for us. And if I forget anything, that way you guys can ask them. If you have questions on the lecture or the quizzes in D2L and JB Learning, this is also a good time to ask for clarification, or email me and your other instructors for that. All right. So respiratory emergencies. We hit on airway already with the Mod 2 curriculum, but today we're going to get into more specifics of respiratory emergencies. So you need to review your anatomy and physiology of the respiratory system, as well as the terminology that we use with the respiratory system. Understand that that's all still fair game for this examination coming up on Mod 4A. All right, so patients that complain of dyspnea is shortness of breath. So there can be an astronomical number of causes of dyspnea. For us, again, we have to start with a big picture, narrow things down to come down to our field impression and treat our patient. Okay, so starting with our general impression of how our patient looks, we start narrowing things down, their chief complaint and life threats that we see, treating those, decide if they're a priority patient, and then we go down to our secondary assessment, and we either include or exclude things based on the questions we're going to be asking during our secondary assessment. Right? So brief review of the anatomy and physiology. Again, the only working part, or the only place where gas is exchanged and air goes in and out, is the alveoli. Your alveoli look like little sacks of grapes. They expand, they're elastic, they expand when they fill up with air, and they contract when air leaves them, all right? As we get older, remember the elasticity changes. When they are fully expanded, it increases the surface area of those alveoli. And with increased surface area of the alveoli, we get better diffusion across the alveolar membrane, right, through the capillary beds that cover them. So ventilation is the act of moving air in and out. Respiration is the exchange of gases. Make sure you know those two terms. Okay, respiration occurs at the capillary beds of the alveoli, but also at the cells and the tissue cells and capillary beds of the tissues. Okay, so those are the two places that respiration occurs. Ventilation only occurs one place, and that's the air moving in and out of the respiratory system. All of the rest of the structures of the respiratory system, the bronchus, the bronchioles, the trachea, all the way up to the airway, pharynx, oropharynx, and nasopharynx, that's all dead anatomic space. Right? So when we breathe in, we have to overcome that dead anatomic space to get air down to the alveoli. We have to take deeper breaths. So think about all the things that keep somebody from breathing in deeply. We call that the tidal volume. One of the important things that we want to do is make sure our patients have adequate tidal volume, right? And that's one of the things we're ensuring with our primary assessment. Ensure adequate tidal volume. If they don't have adequate tidal volume, we need to fix that problem before we can go on to the next one, okay? So if they're conscious and can follow commands, we can try coaching their tidal volume and breathing rate. If they're not responsive, then we're going to have to assist them with ventilations in some capacity. Also remember that we have the CPAP. CPAP is very, very useful because it causes that pressure that you breathe out against, that PEEP, right? It's like breathing in and out with pursed lips, like you're blowing up a balloon. We create a pressure by putting our lips together. That PEEP, right, keeps the alveoli inflated longer. If somebody's in respiratory distress, we can use that CPAP. All right, so in the alveoli, oxygen, carbon dioxide exchange. And then we have different receptors throughout our body. They're called chemoreceptors. And those sense the changes in carbon dioxide. Remember that we breathe on the stimulus of having too much carbon dioxide in our body. Right? And the backup system to stimulate breathing in our brain, that's called hypoxic drive. We're so used to having people that are running on hypoxic drive are so used to having that higher level of carbon dioxide all the time, they build up a tolerance to it. So when they build up a tolerance, the backup system, because it's important, so we always have a backup, that is, hey, I'm becoming hypoxic. The cells become hypoxic. And remember, the brain and the heart are the two most greedy organs that we have for oxygen. So when those two become hypoxic, we end up having problems with respiratory patterns. All right, so that's why it's important to pay attention to patients' respiratory patterns. So stimulation of the brain is based on those chemoreceptors for our primary stimulus to breathe, and that happens in the brainstem. That's where all of our primal functions occur. All right, when those aren't working, we're on hypoxic drive, and that's just the brain is becoming hypoxic as a whole. All right, so things that can hinder the oxygen exchange. All right, so anatomy and the conditions of the anatomy of the airway. You can have traumatic issues, you can have medical issues. Say you have swelling of the airway, swelling of the tongue, right? Foreign body airway obstruction. Those things hinder the structures and make it hard for air to get down. That screws up the VQ ratio. And there we are again with that VQ. Ventilations and perfusions screws up the ventilation part of the VQ ratio. And we talked about that back in chapter, mod 2, all right? All right, disease processes also can hinder the exchange of gases. Things like emphysema, bronchitis, pneumonia, those things hinder the exchange of gases. If somebody has fluid in their lungs, the fluid is heavier than the air, so it displaces the air, gas exchange isn't as efficient, and it can occur. With emphysema, somebody has emphysema, the elasticity has gone away. They've had a hardening of those, the alveoli, right? They become more stiff and they can't expand and contract. It's like a balloon that's been blown up 100 times. It doesn't shrink back down. So they have a greater anatomic dead space that they have to overcome with deeper breaths. That's why people that have respiratory diseases tend to have a barrel chest to them, because their body has become so accustomed to having to take a really deep breath. Trauma also, we talked about that with mod 5, and chest trauma. So ribs, fractures to the ribs are super painful. Can't take that deep breath, the adequate tidal volume, all right? But we can also have trauma to the structures of the airway itself. We can have compression trauma. We can have contusions of the lungs. And then we have abnormalities in the pulmonary vessels. That's not something that we can really do a whole lot to fix, but if the pulmonary vessels have abnormal shapes and oxygen's not getting down to them, things can also be obstructing those pulmonary vessels, the blood vessels, like a pulmonary embolus or a clot. That doesn't allow the blood to get down where it needs to exchange. So now we have a VQ imbalance on the Q side or the perfusion side. Right? There's also certain types of diseases like anemia where your body doesn't produce enough red blood cells, so you don't physically have the red blood cells to go down and exchange for the oxygen to bind to go down and exchange the gases. Sickle cell anemia is another one. That's where the red blood cells are a funny shape and they don't bind oxygen the same way that normal shaped blood cells would be. So what we need to do, we need to recognize patterns of adequate and inadequate breathing in an adult, okay? So adequate respiratory patterns, so we have those numbers, right, that we need to remember. So we're breathing at a rate 12 to 20. Now I know if I'm sitting here calmly, my respiratory rate is probably gonna be lower, but I look at the whole picture, okay? What's my skin? Skin sign tells us everything. Am I making noises when I breathe? Snoring, remember the tongue is the #1 most common airway obstruction. People that have their tongue slid back into the back of their airway make a snoring respiration. Do they have upper airway constrictions, stridor respirations, lower respiratory problems, gurgles? They end up with, mucus in their lungs. So those are lower respiratory sounds. We can also have wheezing. Wheezing occurs when there's a narrowing of the respiratory tunnels, right? The trachea, the bronchiole. So when we have those narrowed because of things like asthma or an allergic reaction, air gets down, but it has a hard time getting back up. So it makes a wheeze on an exhale, right? Then we talked about patients who have that hypoxic drive. So they have a higher carbon dioxide level in their body. We have to use care when we're administering supplemental oxygen to them. And back when we did the mod 2 review and the airway review, think about things like the Venturi mask. The Venturi mask reduces the concentration of oxygen that they're going to be breathing in through a Venturi effect. So this is a list. Again, I hate lists, but things that can have an associated shortness of breath with them. So pulmonary edema, edema is fluid, pulmonary is the lungs. So we have fluid in the lungs or in the alveoli. Hay fever, which is another fancy word of saying allergies, like our seasonal allergies. Pleural effusion is where fluid builds up in the pleural lining, right? You have the parietal pleura and the visceral pleura, and there's that space between. That space should be nice and smooth. It should have surfactant. Well, fluid can build up in that, and as the fluid builds up in it, there isn't as much room for the lungs to expand and contract. The other thing that can happen is when their intestines are really, really full, like after Thanksgiving dinner, it feels like it's hard to take a deep breath. A woman who's pregnant in the late stages of pregnancy, because everything's pushing up on the diaphragm. Obstructions of the airway we've talked about. Hyperventilation syndrome occurs for many different reasons. Sometimes people who have panic attacks start having the hyperventilation syndrome. The brain doesn't start sending it. The brain is getting confused because you're breathing off all the carbon dioxide. So the stimulation to breathe is kind of mixed up in the brain. But hyperventilation syndrome can also occur with acid overdose. Not talking about like dropping acid, but when they take something that's high in concentration of acid. Acetylsalic aspirin or acetylsalic acid is aspirin. So people who have had aspirin overdoses can also end up with hyperventilation syndrome. So don't just assume your patient's having a panic attack because they're breathing really fast and hyperventilating. Environmental and industrial exposure. Again, chemical exposure does a lot of really nasty things to our lungs, and it can do a lot of really nasty things to our lungs over time. Certain drug overdoses. So if somebody has taken an opiate, opioids slow down the brain, so the respiratory center slows way down, right? And they become hypoxic and end up brain dead because they're not breathing, or they're not breathing at an adequate tidal volume or an adequate rate to support the functions of the body. All right, we can also talk about having the functional part. So we've got the air moving in and out, but then we have the functional part where the gas exchange occurs. So gas exchange can be obstructed by a blood clot, trauma, bleeding into the lungs, right? The damage to the structures of the alveoli through a disease process or other damage. Air passage is obstructed, again, anaphylaxis. I would pay very close attention to the signs and symptoms of anaphylaxis as we're going through these last modules with medical. Anaphylaxis causes airway constriction, right, and swelling. So anaphylaxis, the tongue can swell up really big, the upper tissue around the upper airway swells up, and inside the pharynx swells up, which makes the passageway for air very small or non-existent. It also causes bronchoconstriction to occur. So mucus starts filling up the passages, the bronchioles, right? And then excess fluid, we talked about, that's called a pleural effusion. So signs and symptoms of inadequate breathing, you guys can go back and look at this table because there's any number of signs and symptoms of inadequate breathing. I can tell you right now, and then you've heard me say it, those of you that have been in my class have heard me say it, I hate the pulse ox. The pulse ox is a horrible standalone assessment tool. It is strictly a tool to be utilized with other parts of an assessment. Yes, National Registry says that we need to make sure we're oxygenating our patients so that they have a oxygen saturation of 94% or greater, all right? And we use whatever means we need to provide that oxygenation. However, when we're doing that, we have to make sure we're using care, and we got to watch that stupid little pulse ox, because somebody with carbon monoxide poisoning is going to read 100% on there, because carbon monoxide binds tighter to the hemoglobin than oxygen does. It actually kicks the oxygen molecules off, all right? So remember, your pulse ox is only as good as the provider that's using it. Right? I hate it when people use it, and I hate it when people count their respirations or count their pulse off the pulse ox, because all it does is give you a number. All right, infections of the upper airway. So infectious diseases can cause problems with all parts of the airway. We're talking about a big one of that right now. So the COVID-19. So we have the COVID as a type of SARS, and it causes all sorts of respiratory problems in all parts of the airway, right? So airway obstruction from mucus, swelling in tissues, I already talked about that. And then just the alveoli being incapable of inflating large enough to increase that surface area for gas exchange to occur. Right? This is a review of some of the pediatric issues. So you'll see that pop up again too. So I think that was, I want to say chapter 35, was pediatric emergencies. So when we talk about the respiratory emergencies with pediatrics, we're going to say croup is one of those, right? So we see it up to about 3 years of age. You can see it a little bit older. It's an infection, right? It causes inflammation, swelling, a lot of pain to the patient. With croup, they're going to have a seal bark type cough, all right? So they'll get coughing spasms, and it's going to sound like a seal bark. All right, there's a secondary infection. So when we're assessing our patient, they're going to have a fever with it. When you're asking for the history of present illness on there, what have they been doing leading up to this? Have they been sick for a couple days? Have they been having a hard time swallowing or drinking for a couple days? All right. And then the position that you find a patient tells you a lot. Skin color and positioning. If they're old enough, patients can be tripoding or trying to expand. Subconsciously, you're trying to expand your airway out. Just like when you run and you do this, right? Or you put your hands on your hips, that is a way of expanding your airway out. With croup, we want to be careful not to cause more inflammation. We're going to give them oxygen. And remember the ways that you can deliver oxygenation. You can use a non-rebreather, or you can use it by a blow-by method. We have those creepy bears in class. I can truly tell you I've never seen those on the ambulance. But you can use a non-rebreather. You've got to make it a game with this kid, right? So you make it a game and have them talk or breathe into the mask, and they can hear the echo of their voice in it. It's better than nothing. Some oxygen's better than nothing. A 3-year-old shouldn't be tolerating a nasal cannula at all. If they are, you know that they're really sick or that they've had to deal with this before, okay? Also think about if the nose is full of snot and mucus, that nasal cannula is probably not going to be as effective. All right, we have another one for RSV. So RSV is potentially fatal, especially to small children. Newborns and toddlers can end up with RSV 6 months of age. For whatever reason, that 4 to 6 month of age seems to be a big trigger for RSV. This is one of those things, especially if they're in a daycare environment, it runs rampant through the daycare, okay? The bronchioles fill up, become inflamed, and they can't breathe. There's an associated fever with it. There's vomiting that occurs with RSV, and they actually kind of get this weird spider web looking rash on the back of their neck and on their low back or butt. Pneumonia. So pneumonia is one of the biggest killers of patients, the non-traumatic respiratory diseases, killers of patients worldwide. All right, people die of pneumonia. Pneumonia is always a secondary infection unless that patient is immunocompromised. So there's usually something else going on first. Either they can't get out of bed post-surgery, they can't get out of bed or move around as much as they used to. When you're laying flat, you're not taking as deep breaths. When you've had surgery, you're not taking as deep breaths, right? Or they had an infection like COVID causes a pneumonia to occur, right? So we end up with patients that are very sick, especially in the elderly. Pneumonia diagnosis can be a fatal diagnosis in patients in the elderly if it's not caught quick enough. Whooping cough, this is also called pertussis. This is a vaccination we get for whooping cough. It's airborne and highly infectious. It's a bacterial infection, so they can't treat it with antibiotics. It spreads very quickly through age groups. Now, it talks about children under 6 years, although adults can get whooping cough. It's not as severe because our airway structures are larger. These kids are actually whooping when they cough, and their coughing fits are so intense that they wear out all the muscles of their body, all the muscles of their chest, right? On top of that, they have a fever, they're lethargic, they end up dehydrated because they can't swallow, and literally they're just coughing nonstop with that whooping sound, okay? Influenza. So we had a pandemic in 2009, we forget these things, of influenza. And it was actually the largest vaccination push by the World Health Organization to that date for pandemic vaccination for the flu. This was the influenza type A, right? So people with the flu, when we say we're sick and we've got a cold, most of the time it's just a cold and we recover. Flu is legit really, really sick, and people die from it every single year. If you want to get numbers on flu and compare it with COVID, you can go to the AZDHS website, go under infectious diseases, and you can see month by month the flu infection in Arizona. And then comparing that to the COVID infection is actually kind of interesting, all right? Tuberculosis. Tuberculosis is something that you can catch from droplet or particulates that people cough up. It is a bacterial infection. When somebody has tuberculosis, they always have it. It just lies dormant in their body. So Uh, with tuberculosis, we do the PPD skin test, okay? But when somebody has been exposed to tuberculosis, they'll have a positive skin test, but you have to have a time. So if I get exposed today and I go and get a skin test, if I get a positive skin test, it means I was exposed previous to this, all right? Just because that skin test is positive does not mean that you are going to end up with tuberculosis. With tuberculosis, people end up becoming very thin. We see it happen in families where it spreads through families. They end up coughing so much that parts of their lungs cough up if they're not treated appropriately. They end up with night sweats. So high fever and night sweats are two of the things that when we hear that, along with the coughing and the blood or bloody sputum, those are things that we start triggering. Okay, this could be tuberculosis when we're doing our differential diagnosis and trying to narrow down what's going on with our patients so that we can have a treatment algorithm. This is one that we need to use the full PPE. So N95, we're wearing protective eyewear. And then, of course, you have your gloves on because that's standard precautions, right? PPE is going to be eye protection and gloves, right? I also go make sure I decom myself in my uniform after we finish the call. Obviously, we also clean the back of the ambulance with all of these. All right, acute pulmonary edema. So this is acute, means it's happening right now. Chronic means it's been going on for more than 30 days. That's a chronic issue. So with acute pulmonary edema, fluid fills into the alveolar space. We have interstitial fluid, it's plasma, and it fills into the alveolar space and it displaces the oxygen. Think about it like if you take a cup of soda, a paper cup of soda, and you put it out in the sun for a couple days. It doesn't have to have sugar in it, but just a cup of soda. The water part will evaporate out, all right? And it comes out through the bottom of the cup as well, especially if you have a lid on the cup. The bottom part of that cup will start seeping out the water from that soda, all right? And what you're left with inside the cup is a syrup stain from the soda. So that's kind of how our capillary beds are. The formed elements, meaning the blood cells, they can't pass through. All right, platelets can't pass through, they're too big, but plasma can. So plasma enters into the alveolar sac, all right, displaces the oxygen, and we end up with a patient who is having respiratory difficulty, respiratory distress, or respiratory arrest. One of the most common causes of pulmonary edema, acute pulmonary edema, is congestive heart failure. In this module, I will also put the congestive heart failure lecture so you guys can go and view that PowerPoint. All right, chronic obstructive pulmonary disease. So this is the process where over time, damage occurs to the respiratory system from being exposed to something or long-term abuse of the lungs, all right? And it causes this chronic obstruction or chronic cause of obstruction to the respiratory system. So think about the number one cause of COPD is going to be smoking and tobacco use. Vaping now is also causing a COPD. Slightly different in the way it presents itself, though. They call it popcorn lung, right? But after all the years or being exposed to pollution or firefighters being exposed to smoke, or even when we're overhauling buildings, we should have airway protection on, causes damage to the structure of the respiratory system. So excess mucus with COPD is produced, and it obstructs the smaller airway passages all the way down to the alveoli. One of the best things that somebody does that has a COPD, they're going to have a lung butter cough. And remember this is those coughs that they try really hard and you just hear them coughing in the background. You've been in public. I know that you've heard this before. And they're just coughing so hard and you can hear that stuff rattling around when they're coughing, and they could be clear across the store. And after a while, you're like, just get it up, all right? Call that lung butter. That's that nasty mucus that's been sitting down there for a long time. The other problem is when that mucus sits down there, it's a great place for bacteria and viruses to grow because it's body temperature and it's moist, so they can end up with pneumonia in there, right? So we're going to talk about the different types of COPDs. Emphysema is the most common type. Like I said before, the elasticity of the airway is diminished, all right? Now, as we get older, we know that the elasticity of our airway and alveoli diminishes somewhat. When somebody has emphysema, it's an exacerbated form of that damage, okay? When people have a COPD, they kind of have a combined over with chronic bronchitis and even acute bronchitis, but they have those crossover between emphysema and bronchitis, all right? So here we have kind of a blow up picture. To me, it looks like earwax stuck in the airways here, but that's what they're using to show that the obstruction with the mucus, all right, into the airways. Inflammation occurs. That's the swelling of the soft tissues of the airway, which also becomes an obstruction, right? So patients who have pulmonary edema or some types of nasty infection in their lungs, they have that wet lung sound, and again, that lung butter type cough. Some patients with COPD tend to, but don't always have a dry cough with it, unless they've got that secondary infection going on. Right? And we'll talk about asthma and anaphylaxis and allergies. So when we talk about an allergic reaction, we have allergies. If you've lived in Arizona for more than 6 months, you've got allergies to something. We all have allergies here, all right? There's a difference between seasonal allergies and an acute allergic reaction. Anaphylaxis is an acute allergic reaction. The body's immune system kind of attacks something, the foreign material in the body, be it a food, from a sting, a medication, something in the air. And it has this like massive, let's fight it all at once kind of reaction to it. And it's an exaggerated kind of reaction to something that should be otherwise benign, okay? When somebody has anaphylaxis, they end up with airway obstruction and vasodilation. That's why we call it anaphylactic shock. The container gets too big, right? It's a container issue. With anaphylaxis, we administer epinephrine. Patients will have epinephrine autoinjectors of their own, or some of our agencies have a BLS drug box that has an epinephrine autoinjector. This is something you need to know. Epinephrine's dose in an autoinjector is 0.30 for an adult. For a pediatric patient, it is 0.15 for a dose in the autoinjector. And that is weight-based, right? It's weight-based on the patient. So if you have protocols, you can assist your patient with their autoinjector. I've had to use one a couple times, and I can tell you that somebody usually stabs me in the leg with it because it really hurts, okay? With asthma, there's spasm and constriction of the smaller airway passages. And then there can also be a mucus type production that occurs with it. Again, with asthma, air can get down, can't get back up, all right? Some of the hallmark signs between an asthma attack and an anaphylactic reaction or allergic reaction is going to be the upper airway constriction. So stridorous respirations is a whistling type sound, all right, that they have in its upper airway. All right, think about, you narrow that airway passage, it's going to make a kind of whistling sound to it. Wheezing is a lower airway issue, all right, from the constriction of the vessels down low. Asthma affects everybody. So your book says that it's most prevalent in ages 5 to 16. Yeah, 17. Kids can outgrow asthma. There can be a lot of things that trigger asthma attacks. So you don't know, I mean, psychotic PE teachers. Some people have exercise-induced asthma. I can tell you that I can run, but as soon as I stop running, I start having a little bit of difficulty breathing when I'm done. That's just kind of how my respiratory system works, all right? Make sure that you're kind of addressing if it's an asthma attack from an allergic source. Do they know what triggered their asthma attack? It can be chemicals. It can be, pollen, smoke in the air. Those sorts of things can trigger an asthma attack. And then always kind of keep that eye and that high index of suspicion that they can end up with an allergic reaction as well, or it could be in conjunction with an allergic reaction. Hay fever or seasonal allergies, this causes these cold-like symptoms. We all are suffering from that right now in the summer with the wind. Things not hot enough for everything to die off yet. So pets can cause allergies, the dust in the air, pollen from different things. Chemicals can cause allergies. Some people have allergies to makeup, chemicals, things like that. Those are seasonal allergies. Just be aware, allergic reaction, an acute allergic reaction is anaphylaxis. When somebody has an anaphylactic reaction, every subsequent exposure to that same substance will potentially be worse than the previous one, right? Spontaneous pneumothorax, this again is from chest trauma when you think about your mod 5. We can have a non-traumatic spontaneous pneumothorax occur. This can happen in elderly people. Take a deep breath or cough. Some people are just predisposed to having a weakened lining of their lungs. We don't have any real way of knowing that. So you end up with a simple pneumothorax, which is just where you end up with a little bit of air kind of caught in the chest wall space or in that pleural space. Or you can end up with a tension pneumothorax, where that airway is being pushed opposite of the side that the pneumothorax is on, okay? Big thing when we're doing our patient assessment, did they have a trauma or is it non-traumatic, right? How did that happen? So here's another picture again of the spontaneous pneumothorax. Something happens to damage the lining of the lung and air can leak out into the space, right? We can't do anything for it. There's no hole here for air to escape into the atmosphere. So we have to transport them, right? Assess them, put them in a position that's most comfortable, keep their tidal volume up in whatever way you can, and get them to a definitive hospital or definitive care. When you auscultate or listen for lung sounds, I always listen lower to higher. So I compare left to right at each level, and I start in the lower part and I work my way up. Because if they have diminished or absent breath sounds, I want to know at what point, if any, do we start hearing breath sounds again. Remember, you're checking for clear and equal bilaterally. That means on both sides. All right. Pleural effusion, collection of fluid outside the lung, right? Compresses that lung tissue, can expand. They actually make a sloshy sound when they move around. A pleural effusion can occur for a lot of reasons. One of the most common ones is going to be cancer. Cancer causes a lot of really horrible things to happen to your body. Congestive heart failure can also cause it. Irritation and infection, especially if that pleural lining is rubbing against itself, it's going to become inflamed and plasma can seep into that, right? And then even blood can seep into it, and that causes the pleural effusion to occur. The best treatment for pleural effusion for us is going to be having that patient sit in the position of comfort, which most likely will be sitting upright, okay, assuming that they're conscious. And make sure that you're oxygenating them and that you try and coach them to an adequate tidal volume. They go in with a pleural effusion removal, they stick a long needle in, pull all this fluid out into a vacuum jar. It's kind of cool to watch if you ever get to see it. All right, airway obstruction, we talked about this with chapter 13. Again, the most common airway obstruction is going to be the tongue. And I've said that now 2 or 3 times, so that might be important, right? But there can be an object in the airway as well. So we revert to our AHA guidelines for airway obstruction. If they're still coughing and making a sound, we become cheerleaders. And we make sure we're coaching them, all right? Get them transported. When they stop making sounds, they have that silent cough. Adults do this. It's a learned behavior, all right? But kids will have the deer in the headlight look. Kids are chameleons, so they'll change color very quickly, right? They've got that deer in the headlight look and the silent cough. That's a complete airway obstruction. All right, so pulmonary embolism. That's a blood clot in the venous system, all right? When somebody gets a PE, if it's a large PE, it obstructs a large blood vessel and blocks blood flow distal from that vessel. Smaller PEs can end up in the smaller vessels or even in the capillary beds, right? Sometimes they're small enough to pass through, and then patients will cough up this frothy sputum that kind of has a pink tinge to it. But if it obstructs that pulmonary vessel, all right, blood backs up, and we have that VQ mismatch occur, all right? We also get plasma that ends up so they'll end up with pulmonary edema as secondary to a pulmonary embolism. The most common causes of pulmonary embolisms are from deep vein thrombosis. So you have these veins, you have superficial and deep veins that go in your lower legs. So those deep veins, if we are a sedentary lifestyle, we've just had surgery, all right, snowbirds that have been traveling and sitting in cars for long periods of time, people have been sitting in airplanes for long periods of time, their blood can clot. Now, some people are predisposed to that by genetics, and some people are predisposed to it by their obesity or by medication, birth control being one of the most common ones. So they end up with a blood clot in their leg, and then it breaks loose, It has no problem going up through, if we follow a drop of blood, right? It goes into the vena cava, comes back through the heart. The chambers of the heart are nice and big. But when it gets into the pulmonary circuit, it gets stuck, all right? And it gets stuck in that pulmonary circuit and it obstructs the blood flow. So when I'm thinking they might have a PE, we want to see if they've been sitting for a long period of time. Do they meet some of those risk factors for pulmonary embolus? That's part of our assessment tools. Okay. When somebody has those symptoms of pulmonary embolus, they're going to have shortness of breath. It's going to be a sudden shortness of breath, and they're going to have pain that they can point to in their chest. Remember, not all chest pain is cardiac in nature. Hyperventilation. Talked about this before, hyperventilation syndrome. We hyperventilate, you can start getting the numbness and tingling around your nose, mouth, your fingertips start getting tingling, right? It's because we're blowing off that carbon dioxide out of our system. Our body uses carbon dioxide as a buffer to regulate the pH. So we're screwing up the pH of our body, and very quickly do we start seeing the symptoms of that. Just remember that brainstem has to be reset. It can be because of medications, it can be because of acid overdoses, it can be because somebody's having a panic attack. We don't just assume they're having panic attacks, right? Old school for hyperventilation, we'd have them breathe into a paper bag. They're rebreathing their carbon dioxide that way. We cannot do that anymore. So we provide them with oxygenation, and we try and coach them knowing that you are going to be actively coaching them. Deep breath in, trying to reset, all right, the brain's process of monitoring and triggering when we're going to breathe, okay? All right, so somebody who's hyperventilating, it can cause systemic alkalosis, right? And that can cause a whole cascade of issues. Starts with the kidneys and works its way through the body of system failures, right? Can cause dizziness for sure. You sit there and breathe fast for a couple minutes, that's going to make you very, very, very dizzy. It can even cause them to become syncable and have a syncable episode. And I talked about the spasms and the tingling, in the hands and feet. All right, environmental and industrial exposure. So pesticides, solutions, chemicals, chlorine, other sorts of gases that can be released can cause problems with the respiratory system. And we hit on carbon monoxide, although it's not the only one. It is one that is incredibly dangerous, and it's something that goes undetected because carbon monoxide is odorless. Carbon monoxide binds to your hemoglobin stronger than oxygen does, and it can displace it. Our body just can't use it. Pulse ox is going to read 100% because all that pulse ox is looking for is just basically any sort of gas bound to the hemoglobin. All right, it doesn't have to just be oxygen. It's not telling you that it's oxygen. It's just saying their gas is bound to the hemoglobin. All right. So if somebody's running a stove, if they turn on their furnace for the first time in the year and they have a leak, a natural gas leak, they add the smell to natural gas. That can cause carbon monoxide to build up in the house. And you end up, especially in families, we end up with people that causes a really bad headache at first. And then they end up with very progressive and very serious respiratory issues. So carbon monoxide is also present in smoke. It's present in exhaust fumes. So somebody that's working in a garage with no ventilation in it, they can end up with carbon monoxide poisoning. Big thing is you don't put yourself at risk. If you're in that environment, you grab and pull them out. But be aware that you can be at risk for it as well. So scene size up, we know our standard PPE. When you start getting dispatched, we're listening to what's going on. We're listening to the chief complaint. Does that make sense in your head? What equipment am I going to need for this patient or potentially need for this patient? The best you can plan ahead, all right? We can't plan for everything, and dispatchers aren't there on the scene to tell us exactly what's going on, all right? NOI is for nature of illness, all right, for a medical patient. And remember, in the real world, medical and trauma can overlap. In classroom world, we test you separately, all right? Immediate life threats. So again, airway, breathing, circulation. Well, let's start with their level of consciousness first, right? Is there altered level of consciousness? All right, that's a big one. They're automatically a priority patient. Do I have poor general impression? That's automatically a priority patient. If I get down to airway, is the airway open? Is it clear? Then we go down to, are there any injuries to manage with it? Breathing, do we have adequate tidal volume? If not, we got to fix it. Oxygenation on our patients, okay? Can't move down to the next step until we have breathing taken care of. Circulation, is there any bleeding we can control? Any bleeding we can see? Bleeding we can't see, we can't do a whole lot about, but we've got to kind of make sure that we are having that index suspicion they can have internal bleeding somewhere, pulmonary embolus, or yeah, pulmonary embolus in their lungs. And then going down, and evaluating and treating your patient appropriately. Treating for shock is the last step of your circulatory, the circulation part of your primary assessment. It should be like a checkoff for you, right? Oxygen saturation above 94%. That takes care of airway and breathing, okay? Because we won't have that unless we have adequate tidal volume and we're oxygenating and we have an airway that's patent, okay? Bleeding control. We recognize any bleeding, that's circulation, all right? We have a high index of suspicion that there's internal bleeding occurring. Thermally managing our patient for the situation, right? Do we have them in the right position? Again, helps with breathing if they're in the position of comfort. A lot of times that's sitting up if they're conscious. And then are we staying on scene or are we getting them out of there, all right? Transport. This is an example of one way that you can auscultate lung sounds, actually two ways, excuse me, that you can auscultate lung sounds. Again, we're comparing lefts to rights, okay? Clear and equal bilaterally. If it's not clear and equal bilaterally, you need to describe where there's a problem or where there's a deficiency. I also will use the axillary region, meaning the armpit and the sides, on patients to listen for lung sounds if there's a lot of tissue present where these markers are. Because the armpit especially, it tends to have a really thin skin wall, so we can hear easier through that part. Circulation, rate, rhythm, and quality. Pulse ox sucks, right? It just tells you a number, it's not always accurate. So when we're palpating, if they're a conscious patient, we start at the radial. I want to know the number, okay, because that's important. I want it between 60 and 100. If not, it's abnormal. I want to figure out why. Might be explainable, but it's not within our normal. The rhythm, right? Is it regular or irregular? Heart rate should be regular. If it's irregular, that's not normal, so we need to explain that. All right, we need to document it. And then the quality, do they have a bounding pulse rate? Is it weak? Is it thready? Okay, so those are things that we need to explain. Somebody was like, well, what's a thready pulse? The best way I could describe it was I took a straw and a piece of yarn, I tied a little tiny knot in that piece of yarn, had them push on it. When they pulled it through, they could barely feel that little knot pass through the straw. To me, that's a thready pulse. Other people will describe it other ways. And then transport decision. Again, are they a priority patient? Priority patient starts with your level of consciousness. Well, it starts with your general impression. Do I have a poor general impression? Is there an altered level of consciousness? Is there an airway, breathing, circulation, disability, like long-term, this could cause long-term disability, environmental emergency, or exposure? Those are priority patients, right? So make sure we're identifying that and taking them to appropriate hospital. Chief complaint investigation can be very difficult on somebody, especially if they have a very large medical history. So chief complaint, right, what's going on today? When we get our sample history, right, signs and symptoms, that's our OPQRST. But the A is allergies to medications, allergies to substances, right? Medications that they're taking or that they have been prescribed. Not everybody takes the medications they've been prescribed. P is pertinent history. So history that's pertinent to the respiratory system, history that's pertinent to the chief complaint, all right? I also want to know history of present illness. You'll see it documented as HPI. History of present illness. How long has this been going on, all right? What's going on with it? Last oral intake and events that were leading up to it. You know your OPQRST, right? Onset, provocation, quality, radiation or referral. Severity is that 1 to 10 scale. And then is it constant or is it come and go? You also need to ask 2 additional questions. That can be history of your present illness. How long has this been going on for? How long has this episode of it been going on for? All right, have you done anything to make yourself feel better? If so, what did you do? Did it work? Has this happened before? Have you ever gone to the hospital for it before? What did your doctor say? Now remember, with somebody that's having breathing problems, you really want to condense your long answer questions, all right? Because if they are having a hard time speaking 1 to 2 sentences or 1 to 2 word sentences, you want to be very careful about asking them long-winded questions, okay? Because then you're going to need a long-winded answer. So ask your closed-ended questions first, all right? And get what you can out of that. The PACE assessment says just exactly what it means. The PACE is sputum, nasty stuff going up, okay? P is for progression of that sputum, associated chest pain, do they have sputum in general? I also ask them what color it is. I don't need to see it, but I want to know what color it is, all right? Talking tiredness, can they speak in full sentences or are they speaking 1 to 2 word sentences? And then exercise tolerance. Exercise tolerance does not mean you have somebody that has a respiratory complaint and you're getting them to come out and do jumping jacks or run a lap. It means, do they get winded walking to the door? Do they get winded walking to the gurney? All right. Are they tolerating those small movements easily, or is it becoming laborious for them to do so? Your secondary assessment, hopefully you're still looking at your skill sheets, right? And you have them in front of you. You need to pick the body systems. So for secondary, it's 5 points. In the real world, though, you're going to assess what you need to assess. If you have a respiratory complaint or a cardiac complaint, you need to check the other system. So if it's a cardiac complaint, the respiratory system is automatically assessed with it. If it is they say cardiac, if it's a respiratory complaint, cardiac system. If it's a cardiac complaint, respiratory system. Okay, those two are always assessed together. It's your cardiopulmonary system, right? So those two have to function together to have adequate VQ ratio and adequate perfusion, right? And then we go through, check your neurologic assessment. When we check our respiratory system, we can check our lungs. You just need to check 5 things, not necessarily 5 systems, 5 things, okay? Lung assessment, so are we listening to lung sounds? When I expose that particular area, right, we don't have to expose their whole body if it's an isolated medical issue, but I'm looking for rashes, I'm looking for changes in body color. That's your integumentary system, that's your skin. Integumentary systems should always be assessed. 1, it's super, super easy to do. We're already assessing it with our general impression. 2, skin sign tells us everything. Patient's skin will change color depending on what's going on with their perfusion, depending on what they've been exposed to. If they're sick, it changes color, all right? If their liver is failing, their skin changes color. So integumentary system is important and you need to assess that, all right? And then we're looking for other signs and symptoms. You know, history of COPD. Do they have congestive heart failure symptoms and signs? Again, congestive heart failure we talked about with the cardiac chapter, which comes next. But I also put the congestive heart failure lecture back into this folder in the drive so you guys can look at it. You're going to repeat your assessment. When we reassess, reassessment always starts at your general impression. That's the first step in our primary assessment. Has my general impression of this patient changed? Yes or no? Okay, they gotten better or worse or stayed the same. Level of consciousness, has that changed? And then we check our airway, breathing, circulation. If we make an intervention at all, we have to reassess that intervention. Coaching respirations is an intervention. Providing oxygenation is an intervention. Proper positioning is an intervention for our patients, okay? You need to make sure that you're reassessing those when we go back down. And it starts at the first step of our primary assessment, okay? Your interventions include oxygenation. What do they tolerate to maintain their tidal volume? Remember, we have non-rebreathers, we have nasal cannulas, and we have bag valve masks. Bag valve is that positive pressure. And then don't forget, you also have CPAP. CPAP is one of those tools that you can utilize, right? And it is now becoming a standard of care for BLS in Arizona. National Registry also uses CPAP. It's fair game for BLS. Medications. Anytime we've administered or assisted with administration of a medication, you guys will go through the 6 rights. Again, that's in your pharmacology chapter, but you want to double check those, all right? Do we have the right patient, the right route, the right dose of the medication, the right time of the medication? How long does it have to be spaced out? You know, do they have to be spaced out 5 minutes apart? Do they have to be spaced out 3 minutes apart? Right indications for that medication, and then make sure we're documenting it. Document the time that that medication was given. Was it given on an order or by a doctor's order over the radio? Was it given based on a standing order that you have? And then reassessment, okay? Did that medication work afterwards when we're reassessing our patient? How are you feeling now? You told me that your breathing difficulty was at an 8 when we first assessed you. How would you rate your breathing difficulty now? All right, compared to that. So those are parts of our reassessment that we're performing. All right. Make sure that it talks about monitoring respirations. You're monitoring the tidal volume. And I hate that we don't use tidal volume enough in here. Tidal volume is the amount of air you're breathing in and out in one breath. Okay. That's important because you have to have enough tidal volume to go down to the working part of the lungs. All right. MDIs are the inhalers. The dose is the same every time we squeeze it down. we can't utilize all of those MDIs. So albuterol, some of us have protocols in place that we can use. We actually carry albuterol in a BLS drug box, and we can administer an albuterol breathing treatment, all right? Some people have their rescue inhalers with albuterol, but I can tell you most asthmatics will max that out pretty bad before they'll call 911. Asthmatics will push themselves until they can't control it themselves anymore. So it's real important to ask them how many doses of this medicine have they already taken and in what time frame, because albuterol can do some really nasty things to your heart if you take too much of it. Not only does it speed your heart rate up, but it also can push potassium out of your cells. So we need to be very careful about that, all right? And then some medications like rescue inhalers and also epinephrine, they cause bronchodilation, all right? So they counter the effects of the constriction part of those respiratory disease processes, opens up the airway, all right? So specific terms, so upper and lower airway infections or concerns, we do carry humidifiers on the ambulance, but for short transports, they're not really very useful. We can use them for longer term or people that have been on oxygen for a long period of time, because that can dry out the mucous membranes and it can cause their mucous membranes to bleed, which presents a whole nother level of problems, all right? Suctioning upper airways or putting adjuncts in place if they have an infection, especially with kids, you're going to irritate it more. Kids with croup, RSV, epiglottitis, which you'll have to go back and watch the pediatric chapter, the inflammation of the epiglottis. Their airways, because when they get upset, they're just like little snot and booger machines. So they produce all this mucus that creates even bigger issues trying to clear the airway. So using oral airways or nasopharyngeal airways with upper airway infections is counterproductive, and it'll cause more mucus production to occur. So all we can do is supportive care, position of comfort, monitor their tidal volume, and get them to where they need to go, all right? Acute pulmonary edema, fluid in the lungs. CPAP's great because it also, one of the side effects of CPAP, it pushes the fluid out of that alveolar space. That's just a side effect of it by increasing the thoracic pressure. So CPAP is useful for patients with pulmonary edema, but there are some counterindications for it. You know, if they can't follow commands, if they're in respiratory arrest, meaning they're not breathing at all on their own. If their blood pressure is already low, that's a relative counterindication, because low blood pressure, the application of CPAP can actually cause the blood pressure to decrease even more. You increase interthoracic pressure, blood pressure decreases, all right? But we can also give them high flow oxygen, position of comfort, it's usually sitting up if they're alert and oriented, and transport them. COPDs, all right, if they have a rescue inhaler, not all prescribed inhalers are within our scope to administer, all right? It's albuterol, all right? We can't administer other types of rescue inhalers. And then some of them have steroid inhalers that they use on a long-term basis. So they'll use it once or twice a day at a pre-designed or pre-designated time. We're using rescue inhalers or our nebulized breathing treatments, okay, that we can carry based on our medical direction and our agency. All right, hay fever, again, asthma, you're symptomatically treating your patients, okay? Make sure you're monitoring the airway. Now with anaphylaxis, again, anaphylaxis is marked by airway constriction and vasodilation, okay? It needs quick actions. We don't even have to contact. It's a pre-contact stabilization intervention. We still have to go through a whole assessment, all right? But we have to do it quickly because their airway can constrict to the point where they end up just, we can't do anything after that point, right? It's only one way for air to get in and out. But we are allowed to administer, at least in Southern Arizona, it's a pre-contact stabilization administration of their EpiPen, or if we carry EpiPens with our agency. You still have to make sure the 6 rights are there, okay? Got to make sure that we're giving it the right reasons. I've had people on scenes bring me patients that they administered epinephrine pen to. They weren't trained EMTs, and they were acting like trained EMTs, and that patient was actually having a heart attack. So they administered a medication that was actually could be potentially detrimental to the patient based on the side effects of it. Epinephrine, right, causes bronchodilation and vasoconstriction. So it makes the container smaller, counters the effects of shock, and opens up the airway. It's very short acting though. So if you administer your epinephrine, make sure that you have a plan of what you're going to do next, because epinephrine will wear off you need to either get to a higher level of care, or intercept with an ALS unit, or have a plan to get to a hospital. All right. Spontaneous pneumothorax, again, it's supportive care. That's all we can do. Pleural effusion, it is supportive care. All right. The hospital has to be the one that removes the fluid. Obstruction of the airway, we follow our Chapter 13 American Heart Guidelines. If they have a partial obstruction, we're a cheerleader, coach them. While we're coaching them, we can be getting them moving, getting them loaded up, getting them to the hospital. All right. We don't want to sit there and smack them on the back. If it becomes a full obstruction, we're going to go conscious patient, we're doing our abdominal thrusts. Or if they are unresponsive, unconscious patient, we're doing chest compressions, all right, following our American Heart Guidelines. Pulmonary embolism is the clot, supportive care. That's all we can do. Hemoptysis is coughing up blood. Just make sure that you're clearing the airway. You don't want them swallowing blood. Blood is an irritant to any tissue other than your vascular system. So when they swallow blood that ends up with stomach acid, mixing with it tends to have a return policy, meaning that they're going to start vomiting, all right? And when they're already having trouble breathing and potential airway issues and they start vomiting, we end up with just compiling issues on top of that. Actually, bloody noses is one of the only times I want them spitting, all right? I don't like spitting, it's disgusting. But I want them to spit the blood out into our bags, our emesis bags, because I don't want them swallowing it. Hyperventilation, so we're gonna do our primary assessment again with all of our patients. Don't have them breathe into a paper bag. They might have had them doing that before you get on the scene. Yeah, they're rebreathing their carbon dioxide, but they're also making themselves hypoxic. Coach your patient the best you can. Take a deep breath in. Blow it out like you're blowing out candles. Remember that pursed lip breathing keeps the alveoli inflated longer, but it also helps to reset the brain system to say, okay, we need to slow this breathing down. We need to get back on track. Industrial environmental exposures, decontaminating your patient's a big deal, and you're going to end up having to be decontaminated as well if you enter into a scene that you didn't know. Once in a rare while, we don't know what's in there in that scene until we get into it. Okay, don't put yourself at greater risk. Get them out, treat your patient. Supportive means make sure that you are oxygenating, be ready to suction. Make sure that you are looking for systemic presentations in this patient. When we do toxicology review, we'll talk more about those systemic issues. And make sure you're transporting them and communicating with the hospital what they were exposed to. If you're flying a patient out, make sure you're communicating with the flight crew what they were exposed to and if they were decontaminated, for how long, that sort of thing. Aspiration of foreign bodies, again, aspiration means it ends up in the lung tissue itself. We can't do anything. We can't do abdominal thrusts to get that out. It's down in past the epiglottis, so it's down lower in the trachea. We want to make sure that we're trying to get it, or it's down actually in the bronchioles. If it's still in the trachea, we want to try and get it out. One of the common things to aspirate are people who have had a stroke and they can't swallow appropriately. They've lost the ability to control the muscles of the tongue. So food becomes an aspiration risk. Vomit, when somebody's vomiting, they can end up aspirating vomitus. Water can be an aspiration risk, okay? With pneumonia, they can end up with the aspiration pneumonia from something that they breathed in, some sort of fluid or foreign object, foreign contaminant into their lungs. Tracheotomy dysfunction. So tracheotomy, right? They have the little plastic guard and tube here. And there's only about this much of a plastic tube below where you see the little connection port. And that can slide out. It can also become infected, and it can end up with mucus, because we get a lot of mucus built up right here, all right? Most patients with a trach, if they're able to, they suction themselves, all right? Deep suctioning is not within our scope, so keep that in mind. We can only suction as far down as we can see. Don't want to try, if it's dislodged, it's one thing, but you want to keep that trach in place, provide supportive means to the airway as best you can, and transport them, all right? Asthma, oxygen, blow by oxygen depending on the patient, and then using their metered dose inhaler, their MDIs. Or if we have the protocol and the meds to do it, we can deliver our nebulizers with albuterol. Okay, cystic fibrosis, this is this kind of unique thing that occurs. It's genetic disorder. It occurs more to guys than girls. It causes an increase of mucus production. And it's an increase in mucus production inside the lungs as well as inside the GI tract. So inside the lungs, it's this really thick mucus. And people who have cystic fibrosis, they have to go and regularly have that mucus broken up through percussion therapy. The first time I ever saw it was a patient in the hospital, and I was probably 19 years old, and this kid had bruises all down his back. And I'm like, oh, this is a problem. but it's because they were doing percussion therapy on this kid to break apart the mucus. They have more success now. There's more medications that people can take to treat the cystic fibrosis. They're going to be very thin and pale in statute because, again, the small intestines don't absorb nutrients through them, right, the way that they should because of the mucus that's covering the linings. All right, so that was chapter 15. I'm going to pause this so that I can pull up a video for you guys and you can see what it's like to tap somebody with pulmonary effusions. Okay, I found the video. Well, I found one of the videos I wanted to show you, so let me pull it up. It just describes the thoracentesis, so we'll watch that and then we're going to call it good on this.
Edge of the bed with his or her arms resting on a table. The height of the effusion is determined by auscultation and percussion of the posterior chest wall. With a skin marking pen, mark the needle insertion site. The site should be 5 to 10 centimeters lateral to the spine and at least 1 or 2 intercostal spaces below the top of the effusion. The needle should not be inserted below the 9th rib. If available, bedside ultrasonography can be used to help visualize the effusion. In the patient in this video, the pleural effusion is easily visualized, as are the ipsilateral lung and the liver. Prepare the area with antiseptic solution and apply a sterile drape. Using a 25 gauge needle, place a wheel of local anesthetic such as lidocaine along the superior edge of the rib that lies below the selected intercostal space. Switch to a 22 gauge needle and begin to anesthetize the deeper tissues. The inferior surface of the rib must be avoided since the intercostal vessels and nerve are located in this region. At this point, walk the needle over the superior aspect of the rib, alternately injecting anesthetic and pulling back on the plunger as you advance. Once the needle enters the pleural space, pleural fluid will begin to fill the syringe. Inject more anesthetic at this point to anesthetize the highly sensitive parietal pleura. Note the depth of penetration and then withdraw the needle. If available, a hemostat may be attached to the exposed portion of the needle to mark the depth of the pleural space. Attach an 18 gauge over-the-needle catheter to a syringe and advance it along the superior surface of the rib. Keep pulling back on the plunger as you proceed to the predetermined depth of the pleural space. Once fluid is aspirated, immediately stop advancing the needle and guide the plastic catheter over the needle. When the catheter is fully inserted, remove the needle as the patient exhales or hums. The exposed hub of the catheter should be covered immediately with your finger to prevent the entry of air into the pleural space. Next, attach the 3-way stopcock and large syringe to the catheter and continue to aspirate fluid. When this syringe is full, adjust the stopcock so that it is closed to the patient. The stopcock should be open to the patient only when fluid is being actively drained. If additional fluid needs to be drained for therapeutic purposes, attach the collection tubing to the stopcock and to the evacuated container. Open the stopcock to the patient and to the tubing and allow the evacuated container to fill. Generally, you should remove no more than 1,500 milliliters of pleural fluid. The removal of larger volumes may result in post-expansion.
Okay, so the big thing I wanted you guys to see was look at how much fluid they pulled off of this old lady's chest. That's a lot. And when you have that much fluid in the pleural space, it makes it very, very difficult
Pulmonary edema.
to breathe.
On
So
completion of fluid collection,
we're going to have somebody that's going to be most comfortable sitting upright, and they're going to need to have supportive care to the hospital because that's going to be the only fix for it. All right, so this was chapter 15. Come to the Q&A session with questions about what we went over on the chapter. Make sure that you are reading the chapters, you're doing your quizzes online and keeping up with those. And that will be it for this one.